I'm your host, Dr. Jennifer Stewart, and thank you to iGanix for exhibiting at tonight's event. Just some reminders, for each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with your OE tracker numbers. We also have a QR code at the end if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and make sure you ask questions throughout the presentation using either chat or Q&A on your screen. Here's where you can find it on your phone. And it is my pleasure to introduce Woo You favorite, Dr. Mile Brujic. He's a 2002 graduate of the New England College of Optometry. He's a partner of Premier Vision Group, a successful two-location optometric practice in Northwest Ohio. He practices full-scope optometry with an emphasis on ocular disease management of the anterior segment and specialty contact lens. He's active at all levels of organized optometry. He's on the editorial board for a number of optometric publications, has published over 500 articles, and has given over 2,300 lectures, both nationally and internationally, on contemporary topics in eye care. Welcome again. We're excited to have you.
Thank you, Jen, and thank you all for joining me this evening. As a point of disclosure, before we get started with the content, it is important that whenever we're giving CE, you do know my financial disclosures. And again, in full transparency, I couldn't be more grateful and thankful for the relationships that I have with the companies that are listed here through either speaking, writing, acting in an advisory capacity, or performing research for the companies. I've always felt that the strongest clinical outcomes come when the optometrist, us seeing patients on the ground floor, are teaming with industry partners that are actually creating these technologies. So again, I've always been at the forefront of really communicating that with companies and also sharing with them where what they're doing really works and maybe where there's opportunities for improvement as well. But saying that, all these financial relationships have been mitigated for the purpose of the discussion. And what we're really going to be talking about is kind of getting into the weeds, getting into the trenches on dry eye. And what I wanted to provide you with was a really practical approach to the things that we're doing. And I think the last time I gave a Woo UCE dry eye lecture was last year, and there's just so much that has changed in that 1 year. So as we go throughout this discussion, what I'm also going to share with you as well too is how we're implementing these technologies within our practices as well too. So again, one other thing that you do need to be aware of with me is that I see patients 3.5 days a week. So everything that I'm going to be sharing with you is not only delivered from the scientific information, but also organically, anecdotally, what we're seeing in clinical practice. And it is amazing when we talk about the diagnostic side of dry eye, because that's kind of phase one of this whole thing, is understanding how to catch the condition. And it's remarkable because what we used to do is we used to think of this as a condition that affected the cornea, which it does, but we primarily thought about it as a corneal condition where the cornea gets dry. So much so that we actually named it that. Our ICD-10 codes reflect that. It's either dry eye syndrome or keratoconjunctivitis sicca. Well, now we understand that these entities, when they're affected, the conjunctiva, the cornea, and the tear film, these are usually downstream ramifications of what's happening more anterior to those structures, which is usually the eyelid. So when I take a diagnostic approach and when I'm looking at every single patient that I'm examining, I'm we're usually taking a logical approach going from the front to the back. And what that literally means is we're just talking about anterior segment. We're going from the very anterior surfaces to determine, is there normalcy or is there abnormalcy? And if they are abnormal, what is that abnormality? And is it contributing to the signs and the symptoms that we're seeing that patient coming into the office with? And to start, I would be missing a massive opportunity to share with you the fact that the eyelid margin is becoming increasingly important. And when we talk about the eyelid margin, we can talk about things that are happening posterior to the lash margin. But what we're really talking about here are things that are happening at the lash margin that can affect things posteriorly. Now, when you look at these two images, the patient on the right, we may note that they have a mild or trace blepharitis. And when we look at the patient on the right-hand side, we can see that this patient has a more obvious or more frank blepharitis. Well, the reality is this is the exact same patient. The only difference with this is on the left-hand side, I'm looking at this individual at a low mag, and on the right-hand side, I'm looking at this individual on a high mag. I want to share with you another example where you'll see me magging up and see what level of difference and appreciation it gives us for the lash margin and the effects and the ramifications that it could potentially have on the ocular surface. So as you can see in this individual, I'm having them look down and I'm examining that lid margin with a low magnification. Now, if I just flip the slit lamp camera one up, you can actually see what a difference that makes when we're looking at the lid margin. When I click it one more up, you can actually see how much more impactful that is from my clinical perspective. And when we click it one more up, so again, on this particular slit lamp, we have 4 magnification levels. You can see the greater appreciation we have for the collarettes at the base of the lashes. You can also see as well to the volcano signs on the far right-hand side here. You can actually see that there's this, because what we expect to see at the base of the lash is we expect to either see a perpendicular skin to eyelash, or we expect to see a subtle involution at the lash margin. And what you're seeing here is you're actually seeing a tenting up of the skin at the base of the lashes. That's nothing more than indicative of a situation in which collarettes are almost going to manifest itself from the base of the lash or the base of the eyelid onto the lash. And the interesting thing we know is when we do see collarettes, it's pathognomonic for a Demodex overpopulation. And we know the downstream ramifications of this. So as we're looking at the ocular surface, we need to make sure that we're thinking about the lid structure. Now, we also can't exclude the examination of the ocular surface. And one of the easy ways that we can look at the tear film, although we can do it in a number of non-invasive ways, we also have the clinical tools available where we can do it with fluorescein dye. This is something that we all have in our practice. And the distinguishing factor here is we're not using fluoresce. We're actually using a fluorescein dye that we simply wet with either saline or water. We place it on the lower palpebral conjunctiva, and you can actually see what the tear film is doing in real time. And you can see both of these individuals have a severely reduced tear film breakup time. We expect it to be at least 10 seconds. And what you can see in both of these individuals is it's drastically reduced. We can also see fluorescein staining, which oftentimes is invisible without adequate fluorescein present on the eyes. So looking at this patient with a white light assessment, you'll oftentimes miss these downstream ramifications. But remember, these are the downstream ramifications of dry eye. This isn't dry eye. This is just the downstream ramifications of what's likely occurring more anterior to it. Now, there are other signals that there is dry eye, and one of those is increased friction on the upper lid, known as that small little lid wiper area located just posterior to the meibomian gland orifice. And this lid wiper area is really what sweeps over the surface of the eye. And when there's excessive friction between the lid margin and the globe itself, if we place stain on the eye, we'll actually see stain absorb into this region because the tissue is aggravated. And we can actually grade it based on the Korb grading system. So when you're looking at these individuals, you're thinking about grading it in one of two ways. You're looking at the horizontal length and you're looking at the sagittal width of the staining. You're looking at the length, you're just estimating it based on the cornea, and that's what I would typically use. And most corneas are between 11 to 12 millimeters, so that's kind of a good gauge to give you approximate width or horizontal length, I should say. The sagittal width, the way that you do this is how much of the lid wiper area is encompassed by staining. So the staining that you see is right here that I'm highlighting. But when you look at the lid wiper area, you can actually see it as a small little involution when you have that upper eyelid inverted. And because of that, see in this instance, it's a little bit over 75% of the total sagittal width. So these are ways that give us indication that something is wrong. When we see this, we need to be thinking, well, what do we think is the major contributory factor? Now, as we go through the discussion, if I'm sharing with you anything that you have questions about, make sure, like Dr. Stewart said, you're putting them in the Q&A section. We'll be stopping periodically throughout the presentation if there are questions, so that we can make sure that those are addressed. There's other diagnostic tools we have. Now, Right now, there's a global shortage of inflammadries. So if you have some left over in your practice, you still have the ability to use these. But we ran through all of ours, so we unfortunately don't have even access to this right now. Hopefully, we'll be getting access to it shortly again. But the way that this test is performed is you take a small sample from the lower palpebral conjunctiva, you actually snap it in the test cassette, dip it into the buffered saline, and then you wait for 10 to 12 minutes to determine what will happen, excuse me, with the reading window. And you'll get one of three results. Result one is you won't get anything. You won't get a blue line or a red line. If that happens, it's a poorly performed test. It's invalid. If you get just a blue line but no red line, that means the patient has very low levels of inflammation on the eye. For the purposes of MMP9s, it's less than 40 nanograms per milliliter, which puts that individual in the normal range. And if you see a blue and a red line, you know that that patient has inflammation levels or MMP9 levels that are above normal range, greater than 40 nanograms per milliliter. And what's interesting is when Dr. Kading and I started doing this years ago, we actually saw a differential in the signal strength. We saw that some people had a very, very faint red line, and some people had a very, very strong red line. And that is nothing more than indicative of what is essentially happening in terms of the concentration of the matrix metalloproteinase. So this, or the darkness of this red line, is directly related to how high or how low the concentration of MMP9 is in the tear film. Now, the Scout Pro is the evolution of what most of us uh, used to call Tear Lab. Tear Lab was a test that measured tear osmolarity, and the Scout Pro does this as well. The biggest difference between the Scout Pro and the Tear Lab is that the Scout Pro is much more stable. So it doesn't require as controlled of an environment to perform it in, and the test results come back much quicker with this. But essentially, what we're looking for here is tear osmolarity, knowing that a higher tear osmolarity reading is much more likely to be indicative of a dry eye patient. And when you see differences between the two eyes, for example, maybe a 320 in one eye and 290 in the other eye, that's another indication that there's maybe something occurring there. And then, of course, when we're thinking about the lids and the lid margin, one of the we're thinking about is looking at the meibomian glands. Now, you may be wondering, wait a second, he said go from the front to the back. Why is he now showing us the meibomian glands and assessing the quality of the meibum coming out of the glands? Well, there's a specific reason for that. I'm actually kind of giving you insights into my approach on how I examine these patients. So what I do is I put fluorescein on the eye, and the first thing I do is I have the patient look down, hold the upper eyelid up, and just look at the lid margin to see if there's the presence or absence of collarettes. Then what I do, because the fluorescein's already on the eye, is I assess the ocular surface, both with a white light and with a cobalt blue light on the slit lamp and a rat number 12 filter. And from there, you can see all of the surface staining that may or may not be present. And you can also get a sense of what the tear film breakup time is. And if you avert that upper eyelid, you can determine whether or not there's the presence or absence of lid wiper epitheliopathy. Then I pull back and I start looking at the meibomian gland function. And the reason why I wait to do this after I've examined or assessed the ocular surface is because I don't want the assessment of the tear film to be influenced by meibum that I may have inadvertently expressed by pressing along that lid margin. And what you can see in this instance is this is a case of an individual who has obvious meibomian gland dysfunction. Again, a capped gland that's present there. Now, this is easy to pick up, and it's certainly one of those situations where we can truly tell, yeah, it's easy to detect this individual because they have capping of their glands. The one that's a little bit trickier is something that we refer to, and Don Korb initially put in the literature about 15 years ago now, referred to as non-obvious meibomian gland dysfunction. This is a situation where when you look at the lid margin, that lid margin itself looks normal. There's no inflammation and you don't see any capping. But when you attempt expression, either with a gentle press of your finger or with a meibomian gland evaluator, you're simply not seeing any meibum coming from the glands. So again, by definition, this describes a situation of meibomian gland dysfunction. Now, you'll see that when you press with the meibomian gland evaluator, it's about 5 meibomian gland orifice that you see within the width of that meibomian gland evaluator. So when you look at any of the studies on meibomian gland dysfunction, they usually use a meibomian gland evaluator because that width they know is 5 meibomian gland orifice, and it gives them the ability to assess each one of those. Now, Mybography is one of these things that's really become popular over the last several years, but I'll tell you that, and I'm a strong proponent of high technologies, and we certainly have mybography in our practice, but you don't need it to see meibomian gland structure. I'll give you two real examples. On the left-hand side is a patient who I just pulled their lower lid down, took a picture with the iPhone just for demonstration purposes, but I don't usually take a picture of that. I usually just pull the lid down just to see what the inner surface of the lower palpebral conjunctiva looks like. And what you have there is the ability to see where the meibomian glands are and where they're absent. So again, you can see it without any type of specialized technologies. On the right-hand side, what I'm doing is probably one of my favorite techniques to do at the slit lamp, which is eyelid transillumination. So you take a standard transilluminator, you turn your slit lamp light off, you turn the exam lights off. So again, you're doing this during the slit lamp evaluation. The only difference is the only light source that you're utilizing is the transilluminator. And then what you do is you take that transilluminator and you shine it through the lower eyelid. So you leverage that lower eyelid so that you're seeing so what you're seeing here is the inside surface of the eyelid or the palpebral surface. And you shine light through the bottom of the eyelid up through the lid. And when that happens, you'll actually see these dark shadowed areas where the meibomian glands are located because again, light can't go through the meibum. And where the meibomian glands are not, you'll actually see this red or this dead space right here. So you can see in this individual, there's a frank shortening of the meibomian glands. We certainly confirm it with infrared technology, but this is a great way to screen these patients that you're seeing in your office to determine what is the meibomian gland length on these individuals and what are you working with? Because this will ultimately be the guide on how we explain what our treatment potential is for these individuals. For example, when you look at the traditional Hyco scaling and you look at the degree of dropout, you can see on the left-hand side the level of dropout going from 0, which is all glands intact and looking normal, to gland dropout of degree 4, which is greater than 75% of the glands being dropped out. And you can see everything in between. But if I have a patient walk into my office who has full-length glands like this on the degree 0 loss, so no meibomian gland structural loss, and when I'm pressing along the lid margin, they don't have adequate meibum coming out of those glands. I know that with some type of treatment, usually procedural based, I know we can get those glands functioning better. And I know that the expectations for this patient are very, very high in my mind. There's one other thing that's going to dictate that I'm going to talk about in just a second. But I feel good about that patient because they still have a lot of structural gland present. If I have this patient right here in my chair, so it's a degree or grade 3 dropout, and you can see some of the glands are completely dropped out, other glands are severely shortened. This is much more of a cautious outlook for this individual. This is somebody I'm much less optimistic with results. We still want to get the glands that are functioning. We still want to make sure that we're getting those functioning optimally. But the reality is we can't expect the same results or the same meibum function from glands that are over 50% dropped out versus those that haven't dropped out yet. And one of the things that's also become very, very interesting over the last several years is the facial appearance of these individuals. In particular, if you're incorporating procedures specific, so that facial rosacea has a strong association with ocular rosacea. And one of the questions I always ask patients is, are you wearing any makeup today? And when I have female patients that I ask that question, almost every single time they'll say, nope, I didn't wear any eye makeup. And I say, are you wearing any makeup on your face today? And usually they'll say, oh yeah, I'm wearing some cover up. And I ask them what their appearance or facial appearance looks like. And I always ask them the next visit, can you please come in wearing no makeup? Because I want to see what the appearance of your skin is. Because oftentimes these individuals don't even know they have a diagnosis of rosacea. And that may set the precedent on how we actually treat these individuals. Because oftentimes they will have a hyperemic, telangiectatic, inflamed lid margin as well, too. So I want to go over two more diagnostic kind of strategies here that over the last 5 years have become more important in our office. One of them being very important over the last year. The other one we've incorporated over the last 5 years, where now every single new dry eye diagnosis gets both of these tests. And anybody that's recalcitrant to dry eye treatment gets both of these tests as well too. So when we think about corneal sensitivity, it's all drawn by the ophthalmic branch of the trigeminal nerve, which branches into the nasociliary nerve, which ultimately branches into the long ciliary nerve. And the long ciliary nerve and the nociceptors on the end of the long ciliary nerve will ultimately give us our perception of pain on the surface of the eye or dryness on the surface of the eye. The reality is that nerve actually communicates with a secondary nerve in the central nervous system. And that secondary nerve then sends that impulse to the tertiary nerve, or a higher level nerve, or a third order nerve, to the cerebral cortex, where we'll ultimately feel our perception of whatever it is we're experiencing. So why do I share all that? Well, this is one of these tests that I think have become a gem in the practice. It's the Prepare Cane Challenge test. Some of you may be very familiar with this test, others of you may not, but this next piece right here that I'm going to be talking about, if you're really serious about caring for ocular surface patients at a high level, this is an extremely important test. So here's how it works. In the chair, you ask a patient, rate your dryness right now, your right eye and your left eye. Give me a number from 0 to 10. 10 is the worst you can picture your eyes feeling. 0 is the best you can picture your eyes feeling. And let's say, for example, they give you a 7 for the right eye and a 7 for the left eye. Now, then we drop a Prepare Cane in the eye. We wait about 60 to 90 seconds, and we ask them that exact same question again. Now, what we would expect for a standard dry eye patient is we would expect their perception of eye dryness to drop down to 0. Again, that's what we would expect. We're inhibiting the nociceptors at the end of the long ciliary nerves that go through the cornea and innervate the corneal epithelium. But what happens if they don't go to 0? What happens if they improve a little bit? They go down to 3 or 4. What happens if it doesn't change it at all? What happens if you put Prepare Cane in the eyes and the eyes actually feel worse after the Prepare Cane Challenge test? So we record this on every patient. The way we do it is prop test. This is just our jargon. Prop test, pre OD number, OS number, post OD OS, so that we can see if it's influenced or changed. Well, why are we doing all this? Well, the reason why we're doing this is we very, very quickly determine whether or not the eye dryness the patient's experiencing is all from the nociceptors, or essentially the receptors at the end of the long ciliary nerves at the terminal ends of the cornea, or if this isn't 100% influencing what the patient's experiencing. And there may be, in that instance, a neuropathic component to it, or a central component. We have to communicate to those patients different. If I put a Prepare Cane drop in the patient's eye and they say, my eyes are still burning, they're still dry, that is a completely different subset of dry eye, and it requires a completely different discussion. And I'll share with you how I describe that to patients. There are two types of dry eye, one that's very predictable when we treat it, and one that isn't very predictable. You have the second form. And the reason why I say that is the perception of dryness that you're experiencing isn't from the nerves in your cornea that are being irritated because of the dryness. It's actually something centrally where a signal is being triggered, and it continues to send a signal of eye dryness. So it just requires a different conversation for those patients. We've had more people cry in our chair when we've told them they've had neuropathic dry eye than any other thing that we've done. And the reason why I say that is because they look at me right after I described it to them and they say, "You're the first person that I feel like I'm describing these symptoms to that I'm not crazy." And I always tell those patients, I don't have a degree to determine whether or not that's the case, but what I can tell you is what you're experiencing is real. No, I'm just joking. I don't see the first part. But what I do tell them is you have a specific type of dryness that people may have rehabilitated your ocular surface. It may look great, but the reason why you're experiencing this is more centrally driven. And here's the steps that we're going to take to make that better. We're going to talk about what those are in just a second. I'm going to share with you one more diagnostic, then we're going to pause for some questions here. So, corneal anesthesiometer, we brought this in the office a year ago. Um, thinking that we were going to pick up a lot more neurotrophic keratitis patients. In addition to that, what we found is some amazing stuff, which changes the way I'm communicating with patients. So this is the Brill aesthesiometer. And to give you perspective on how it works is there's 5 levels of air puffs that it sends along the surface of the eye. So the patient sits at the slit lamp and you just press the button, puts a little puff of air on the eye. It does it at such a light level that it's a fraction of what a non-contact tonometer does. And just for references, non-contact tonometer typically delivers 250 to 300 millibars of pressure to the eye in terms of that puff of air. This instrument's delivering anywhere from 1 to 10 millibars, so it's a fraction of it. We're just trying to see, can the patient feel it on their cornea, which is the most sensitive part of their body. And what we actually have is level 1 being the weakest signal, level 2, 3, 4, 5, increasingly creating a larger signal of a puff of air to the eye. And what most normal people can feel is level 3. If you can't feel level 5, you have a numb cornea. You're supposed to be able to feel at least a level 5. But normal patients usually will not feel a level 1 or a level 2. But what we found is with our dry eye patients, in particular, our most symptomatic dry eye patients, those individuals can detect level 1s and level 2s. So I tell the patient, I say, I can see why you're so sensitive when you go into department stores, when you go into these different environments, when you go outside, because your corneas are more sensitive. Through this rehabilitative process, what we're going to try and do is we're going to try and reduce the sensitivity of your cornea. That's crazy because we're always talking about with neurotrophic patients how to improve the sensitivity. We're going the exact opposite way with these dry eye patients, and we can objectively measure it at this point. All right. So, Dr. Stewart, why don't we jump into some questions here?
All right, so a bunch have come through. So
Cool.
let's see, let me read off some. All right. Um, is inflammatory legal in all states, if you know that?
It is legal in all states. The only question I can't answer for you is, do optometrists in every state have the ability to send for CLIA waived tests? And I don't know the answer to that. I think there was a few that they couldn't actually utilize CLIA waived tests, but
Okay.
that would be something that you'd have to check with your state association with any point of care test, including tear osmolarity as well too, because it falls in that same bucket.
Do you know why there's a shortage for inflammatory?
I have no clue. I have no clue.
COVID,
I think
something.
there's going to be some point in time where we got to stop blaming COVID for
I
stuff.
know.
But it's not yet. We can still blame it. We're still close enough to it
Not
that we can
yet.
still blame it.
Not yet. Do meibomian glands ever regenerate with treatment?
Okay, this is such a good question, Jen. There were anecdotal reports that meibomian glands did regenerate themselves. Here's the caveat with that. When you're looking at standard infrared images, infrared, all it does is measure metabolically active tissues. So when you pull it down and you shoot infrared technology at it and image it, all it's doing is it's telling you, the meibomian glands are more metabolically active than the surrounding tissues, which is why the meibomian glands are white and the surrounding tissue is gray. It's also the reason why the software will take that and then accentuate that and make it whiter and the surrounding tissue darker. There were anecdotal reports that, oh boy, after you do like this thermal expression and evacuation techniques, you're starting to see the regeneration of it. What we think was happening is you're actually creating more metabolic activity in the distal portions of the glands that were there. They just weren't getting picked up on traditional infrared technology. There is one infrared technology where you take the light and you shine it through the lower lid and then you infrared image it and it spins the colors. So the meibomian glands look darker and the surrounding tissues look lighter. That's really the only way that you can tell whether or not the meibomian glands are truly regenerating. So I think that what we saw in those reports were the meibomian glands were becoming more metabolically active in the distal portions of the gland as opposed to truly regenerating.
Correct. Do you always find decreased corneal sensitivity in post-refractive surgery patients?
Yes. Let me rephrase that. immediately after the surgery, yeah, but saying that, that doesn't mean they're going to not come in complaining about dryness. That response is so sometimes counterintuitive because sometimes the peripheral nerves are still there, and as they're growing back, they're more sensitive as well too. What's remarkable, we don't have in vitro or in vivo confocal microscopy, but there's a lot of studies that show that dry eye patients have a lower density of these nerves, but they're more sensitive. It doesn't make sense. They have these kind of like glial outpouchings, these neuromas that make them more sensitive. So even though they have less nerves, they're more sensitive. We think that's maybe what's happening in some of these refractive patients. But early on, there's some that are very reduced, and there are some that are actually hypersensitive. And there's no way to predict which patient you're going to be seeing post-refractively.
Perfect. Are you going to get into treatment in your presentation? Because there's a lot of questions about treatment, but I figured
Right,
we would hold on to that. So I think with
right
that,
now, Jen,
there all the
we're going to
questions
dive
in
into
there we
that.
can wait on. So I will turn it back over to you.
Cool. Jen, thank you. And the way that I wanted to break down treatments were in two buckets, procedures and topicals or pharmaceuticals. This is becoming increasingly important in our space. And it's remarkable to me, like when I look at my typical day to day and I compare it to a typical day 15, 20 years ago for that matter, it's remarkable how procedural we've become in this space, in particular with all the stuff we can do in dry eye. So let's jump right into it and where it may be most effective, because those are the two questions you always want to ask. You never want to bring in a procedure and say, all right, I'm now going to create a dry center of excellence because I brought in this. You have to actually see where the patient need is and say, oh, got it. I know that that technology can fit with these patients. And we're going to talk about all of those nuances with all these procedures. So the first one is Rinsada. This is probably the easiest, lowest cost, and one of the most kind of quickest bangs for the buck you can get. Because what you do with this device is it's a small little end that you put on a 10 ml syringe that's loaded with saline. And the end has five little holes that squirt saline out of it, two that go back towards itself, one that comes directly out of the hook, and two that go away from it. And really, how this procedure is performed is you literally, as its name implies, you're rinsing the surface of the eye and you're resetting the ocular surface essentially. So you get all of the stuff that's grown over there during a patient's lifetime that we really never get a chance to truly clean. We're now really doing a thorough flush on all of that. And there was a study that actually looked at Rinsada rinse compared to a standard saline rinse, because even a standard saline rinse is good for patients. But they found that the inflammation reduction that you saw with the Rinsada rinse was much more so than just a standard saline rinse with a bottle. And what they also found was they objectively measured it with inflammatory readings, and they found over 50% of these patients a month later were still inflammatory negative after that study. The reason why I share all of this is because this is a tool that we've incorporated whenever we experience inflammatory dry eye. We've also coupled it with a lot of our other procedures. So, for example, after the last IPL, we'll usually combine it with RF. We'll usually do an expression after that. And then we'll do a nice Rinsada rinse before the patient leaves. The thing that we always do right before the patient leaves is a drop of Lumify in the eye, because whatever we've done, we may have subtly irritated the eye temporarily, but Lumify makes them look better. And when you look better, you physically feel better as well too. So it's a nice adjunct as a primary treatment to start, like before you're going to start pharmaceuticals, to just reset the ocular surface. And also as well too, like after you've done procedures to make sure that that lid margin is nice and clean. In addition to that, for patients who come in like with those hot red eyes, specifically allergic conjunctivitis, they love the Rinsada rinse, and then you start them on a corticosteroid and or a antihistamine mast cell stabilizing agent. In addition to that, if you have somebody that got stuff in their eyes, it's just a nice way to make sure that you got everything out of their eyes. Now, there's a lot of discussion around biofilm on the ocular surface, and we have several ways to actually treat the lid margin. One is through microblading blepharoexfoliation. And we can do that through either an instrument called the BlephX, and you can see it in action on the right-hand side. And there's also a little bit a gentler way to do this as well through the new lids system as well, which provides gentle vibrations along that lid margin as well. There was one thing that was recently presented in the literature referred to as the Reinerson red line. Jim Reinerson was the individual who actually created the BlephX. And what he describes is, and you can see it in these patients here, where you have this normal on the far left, and you have this abnormal on the far right, where you see this red line right above the lid margin here, describing this chronic MGD blepharitis syndrome. And he actually recently created a new technology referred to as the Optivise. And what this does is it creates an electrical current through the meibomian glands, killing the biofilm that's believed to be present on the inside of those meibomian glands. It's a pretty remarkable technology. Now, many of us have um, either foregone traditional punctal occlusion, or we're not potentially doing it quite as much as we used to, because of the thought that, well, we're keeping this is, don't mind me, having a little bit of a hard time putting these silicone plugs in. I had a few drinks before I did this procedure. No, I didn't have a few drinks, but this is me putting silicone plugs in. But we've kind of reverted away from silicone plugs because back in the day when we used to do a lot more silicone plugs, a lot of patients would feel them, and we knew that they would create biofilms on the surface of the eye, and sometimes they'd uh, unintentionally just kind of fall out of the punctum. But we were always taught that we needed to clean up the inflammation before we occluded the puncta. And the reality is that may have been an incorrect misnomer that we were taught years ago, and it made sense. And we just said, all right, we didn't challenge it. Well, this was actually the study that challenged it. It asked, what are the effects of punctal occlusion on inflammation levels in the tear film? Well, tear cytokines and MMP9 levels, they didn't change with punctal occlusion after a 3-month time period. So again, this is the proof that shows that we're not increasing inflammatory levels with punctal occlusion. We're not decreasing them, but we're not inadvertently increasing them as well. So many of us have actually started migrating towards these intracanalicular plugs. And what do we do with intracanalicular plugs? Well, we put them in the puncta, and then we push them into that intracanalicular tract. Now, the good news is that they'd last, for most individuals, about 6 months or so. You can see a collagen plug on the right-hand side. These are both dissolvable plugs. The one on the right is made of collagen. It lasts about 7 to 14 days. The one on the left-hand side is made of a longer dissolving material. It's not collagen. These longer dissolving materials are made of a similar material that dissolvable sutures are made out of. But the problem always came with understanding the anatomy of the lacrimal drainage system and how different they were in different patients, which made punctal occlusion in some of these anatomies a little bit difficult. And to ask the question, which one of these is the actual correct anatomical description of the canalicular tract, they're actually both right. They're just seen in different individuals and different patients. So relatively recently, about a year and a half ago, we actually now have something called Lacrofill. Lacrofill is a preloaded syringe with 0.5 mLs of sodium hyaluronate gel. This is still considered punctal occlusion. It's still billed with the 68761, which is the exact code that's utilized for traditional punctal plugs. And what you do here is a cannula, you put it on the end of that syringe. I usually use a 25 gauge bent tip cannula. And what you literally do is you press the gel into the canalicular tract through the puncta. And this is me performing the procedure. I do it at the slit lamp. You can see on the left-hand side the way it looks, and you can see on the right-hand side kind of what it looks like and how I'm holding the syringe for that right eye application. And you know when it's full, when you start to see some regurgitation around the base of the puncta and where the cannula is going into the puncta. We'll see in just a moment. Yep. So you see the gel coming back out. So that's when you know we've put enough gel in there. Now, in about 20 to 25% of patients, you'll actually see gel coming out of the upper puncta. But what I wanted to show you before that is how I prepare the puncta. Now, some of you may be using just standard punctal dilators. I don't do that. I actually use a jeweler's forceps, place them in the lower puncta, and then just allow them to open up in the puncta. And that usually opens up the puncta enough to accept a 25 gauge cannula. And then when I push, or then when we put the cannula in, and you'll see this on both of these images, the patient's right and left eye, because if you see this happening in one eye, it'll likely happen in the other. But on the left image or on the left video, I want you to pay attention to the upper puncta here. Putting any gel in that upper puncta, I put it in the lower puncta, lower canalicular tract, and it went through the whole lacrimal drainage system all the way through the top. And you'll see the same thing on the right video here as well, too. You'll see in just a moment. There it is. The gel is starting to come out of the upper puncta here. Okay. So if you see it happening in one eye, you'll likely see it happening in the other eye. And it happens in about 20 to 25% of patients. This is a great adjunct to anything that we may be doing for these patients because what it does is it retains the tears on the eyes. And it also, through a slow dissolving mechanism, places low levels of high hyaluronic acid on the eye as it's dissolving over a 6-month time period. The other thing that's interesting, and we published on this, we did a poster for SECO where we had patients in intracanalicular plugs. We transitioned them to the Lacrophil plugs, and we found that their staining improved. We also published at the AOA, we presented a poster looking at inflammation levels, and what we found was Lacrophil in and of itself actually improved inflammation levels. So there's more to this than simply occluding the puncta. We think part of it is that HA that's slowly dissolving in the tear film as well. Now, we have 3 standard procedures for meibomian gland warming and evacuation. LipiFlow, which is a simultaneous warming of the posterior lid margin while expression is occurring. iLux, which is expression while warming the anterior surface of the lid. And then we have tear care, which is a sequential warming and then evacuation after at the slit lamp. What we do during this procedure is when there's about 2 to 3 minutes left, we'll take off the first one. We'll start expressing that left eye, and then we'll hear the buzzer, and then we'll take off the second one, and we'll start expressing the right eye after that. TearCare actually had some interesting recent wins. So they've tested themselves against Restasis, showing improved tear film breakup time compared to Restasis, improved meibomian gland secretion score, glands yielding liquid secretions, and glands yielding clear liquid as well. But they've recently been approved for reimbursement for some major medical carriers. So again, they've been working on this for the past several years. So stay tuned because that may be a procedure that's soon adequately reimbursed through many of our insurers. This isn't available yet, but it's something that's important to note. It's an eye lipid mobilizer. This thing does 3 things simultaneously. Warms the lids, vibrates along the lids, and puts pressure along the bridge of the nose. And by doing those 3 things, it actually melts meibum. The vibrations actually shear the meibum in the glands, and then the pressure on the outer nasal portion of the nose actually helps stimulate the trigeminal nerve and produce more tears. I want to jump in real quick on light therapy as well. And for the purposes of time, I'm going to keep this brief, concise, but take you right to the point here. Different wavelengths of light penetrate into the dermis very, very differently. And we leverage this knowledge in how we treat patients. So, for example, when you treat somebody with low-level light therapy, which is usually a 3-panel approach that you shine light on their eyes, it's usually red and near-infrared light, we can help do several things. Improve the metabolism in the fibroblasts within the dermis, and this helps them produce more ATP. We can also get those fibroblasts producing more procollagen and collagen-based fibroblastic growth factors, providing a healing region to the surface of the skin that's actually exposed to. And what this actually does is it changes the temperature of the eyelids. It also changes the mechanics of the eyelids as well, too. We don't put shields on patients' eyes when they're sitting for low-level light therapy. And you may be wondering, well, how do we determine whether or not somebody does low-level light therapy versus IPL? Well, IPL is very sensitive to skin tone. So you can't, for example, treat a Fitzpatrick 5 comfortably because, again, you're at risk of depigmenting darker skin. So you're usually working with lower Fitzpatrick scores for IPL. Low-level light therapy doesn't care what the tone of your skin is. You can be a high Fitzpatrick score, you can be a low Fitzpatrick score. Again, it's agnostic of the color of your skin, so it doesn't care. But there was a recent study that showed that low-level light therapy could resolve in 85% of patients who had recalcitrant chalasia. It could resolve those chalasia, and we've seen this in our practice. So this is one of the options we give patients. This is before the low-level light therapy, and this is after on that same patient. So again, it's remarkable what we've seen. We actually put a poster together, a case series of 4 patients looking at this. And again, almost all of them completely resolved over time. So the reason why IPL works is because it targets blood vessels in the dermis, and in doing so, it actually closes them up, reducing inflammation, which reduces ultimately inflammation in the lid margin as well, too, because even though for the original procedures, we were treating temple to temple or tragus to tragus in that periorbital region, we realized we were influencing all this periorbital tissue. And when we do that, it'll eventually lead to less inflammation at the lid margins as well, too. And that's the reason that intense pulse light therapy works for those individuals, in particular for those ocular rosacea patients. Although even for those non-ocular rosacea patients where you see meibomian gland dysfunction, this still works. There's still an understanding around IPL that we're trying to truly understand and figure out, because we don't understand the full mechanism, but we do know harnessing Mother Nature and the power of the electromagnetic radiation, or essentially light, we can actually help people function better. So with that said, Jen, we have one more section on pharmaceuticals, and I'd like to take a quick break for questions if there are any here.
Sure. Let me turn my video on. There are, so you're going to cover some pharmaceuticals, so I will skip any questions that may pertain to that, so we don't want to miss that. Okay, let me get the
Don't want to double
Q&A.
dip.
No, I know, I don't want to steal your thunder. So let's see. Uh, how many treatments do you typically do for LLLT, and what is the typical length of treatment?
Okay, so we do for dry eye, we have different protocols for different things. For dry eye, for example, we'll do 6 treatments. We'll do red and infrared, and each session lasts 15 minutes, and they're separated by 1 week apart. For chalazion, we'll actually do 3 treatments of the same red infrared, but we'll separate them by 3 to 4 days. And there's going to be 3 treatments. And I see the patient 1 week after the third treatment.
There were a lot of questions about that. Somebody asked if you could go back to the slide titled IPL very quickly.
Sure can.
Okay, there we go. Is LLLT better than IPL?
Low level light therapy has a similar yet very distinct different mechanism. Because IPL is such intense light in a short period of time, you actually get more effectiveness on the chromophores. The other thing as well too, Jen, is with IPL, you're actually using a little bit of a shorter wavelength as well too. So with low level light therapy, you're usually using slightly longer, the red and the infrareds, just so you can get a deeper penetration into the tissue. For intense pulse light, you're usually using about a 580 to 590, 600. So you're using just a little bit of a shorter wavelength, but the intensity is much greater with IPL. Just a quick FYI too, there's new, like, so every single one of us who's ever used an IPL know that, like, oh, okay, well, you need to have a cool water running through it to actually cool it so that you can use it. There's actually a new IPL technology that we're using in our practice. This is absolutely insane, but the handle is so light and the handle doesn't have water going to it. So there's no hose or no tube going to it. It's like it's plugged. It's like it's a power cord that it's plugging it into the unit. So this thing is unbelievable. And the ability, or the reason why they can do that is because it's this ultra intense, but very, very short burst of light. And the cool thing about it is we're actually starting to see better results, because when you think about traditional IPL and cooling the skin, you're actually constricting the blood vessels as you're trying to send light to those blood vessels. So when you don't have to put a coolant through it, like we're doing right now, you're just using room temperature. So those blood vessels are in their natural native state, and you can really, really target those blood vessels.
Are you going to get into neurotrophic keratitis?
No,
Okay.
not tonight, Jen.
Okay. There are a lot of questions about that, so maybe we will table that and people can ask you offline. Would that be
Yep,
okay?
100%.
Okay.
100%.
Um, do you have conversations with patients about makeup products?
Kind of. And I don't want to say any websites, but there is a website that was created by practitioners that's a good website. So whenever I suspect that patients are either using something that's garbage, I'll just say, here, go to this website. And we also now use services that we can send direct links to patients' cell phones that they can purchase. So there's a micellular cleaning system that Bausch& Lomb actually creates that's absolutely fantastic. Eye illuminations, it just does an awesome job of getting makeup off. So we have tools specifically, Jen, for dudes talking to women. Like there's ways that I can simplify that conversation and make it a lot easier so I don't go down these rabbit holes where I'm like, wait, what? Wait, what? Like that's the last thing I want to do in my exam room. All right, Jen,
Perfect.
can I go over the pharmaceuticals real quick and then we'll
You
jump into
can.
clinical?
I'm gonna let you go and then I will see you back in a few minutes.
Let's do it. So, when we talk about pharmaceuticals, one of the things that we need to think about, I hate the term artificial tears. I absolutely hate them because there's nothing, ideally, what we want them to be is the least artificial as possible. We want them to be supplemental. So I always tell patients, and it's just a verbiage I've started using over the last decade. And whenever somebody says, yeah, I'm using artificial tears, I go, you mean supplemental tears. That's what we're using. We're supplementing the surface. And really the key indicators of the things that I'm looking for is one, what's the preservatives in the system that are utilized in the system? Ideally, what we want is preservative free. When we're managing the ocular surface, we want to mitigate any challenges. And the store brand products, they're loaded with harsh preservatives. That's one of the main reasons when somebody brings in like brand XYZ, that's a store brand product, I just literally take it and I throw it away in the garbage. I say, you're not using that anymore because that may actually counter the efforts that we're trying to do to make you better. The other thing too is being cognizant of the wetting agents or the demulcents that are in these systems are critically important. And sometimes more isn't always better. When you truly understand how artificial tears are made, it's critical. There's an artificial tear that actually is all organically made. It has a wetting agent that's made from organic substrates, and it has salt and water in it. Those are the three ingredients to it. So when you talk about harnessing the power of Mother Nature, specifically when we're talking about things like IPL or low-level light therapy, which in my mind we are, Rinsada, which is getting rid of stuff on the eye, um, Lacrophyll, which is again just keeping the tears on the eyes and slowly producing a slow leach of HA on the eye. We're thinking about those things that are more organic, and that's one of the most important things that we need to be thinking about when we're thinking about artificial tears, and certainly accessibility. How's patients going to get it? And if you can retail it from your office or from a secondary site from your office, those are all wins for you and the patient, most importantly. Let's quickly talk about pharmaceuticals because there's broad categories. The first is inflammation control, and the first bucket is cyclosporin. Cyclosporin comes in a variety of concentrations now, 0.05%, which is the original Restasis, 0.09%, which is Cequa, which is the thing that makes this different than Restasis is it's almost double the concentration, but the nanomicellular inactives in it actually make it penetrate into tissues better. And then there's 0.1%, which is available as Vevi or Vivi. And essentially what this does is the vehicle allows it to penetrate into tissues in a very, very comfortable way. So you just get a lot more medication in the tissue that's affected. There's also lifitegrast that's in this bucket of controlling inflammation. This is 5% lifitegrast, and this is known as Xiidra. And essentially what it does is there's ICAM molecules on the surface of inflamed cells, intracellular adhesion molecules, and they're overexpressed on inflamed cell lines, specifically the conjunctiva. And what this does is it blocks T cells from interacting with it through acting like the ICAM molecule, binding to the LFA molecule on the T cell without activating that T cell. So it inhibits it and it prevents it from interacting with ICAM molecules. More recently, perfluorohexyloctane at 100% was approved, and this is commercially available as MIBO. Its target is the lipid layer of the tear film, and it acts as an anti-evaporative layer for patients so that when you use it, you keep the tears that you're producing on your eyes for a longer period of time. AZRMD-001 is an investigational component or molecule from a company called Azura that contains selenium sulfide. It's used twice a day, and they're looking for changes in the meibomian gland function over time. I'm sorry, I said twice a day, I meant twice a week. So you use it 2 nights out of the week. Varenicline nasal spray activates the trigeminal nerve within the nasal cavity, stimulating natural tear production from the eye. We talked about the importance of identifying the things that are happening along the lid margin, specifically with collarettes, with their pathognomonic for Demodex overpopulation. And lotilaner 0.25% is actually approved for that. It's commercially available as Xdemvy, twice a day for 6 weeks to be utilized. Most recent approval, and the kid on the block here, is the TRPM8 agonist, which is commercially available as Triptyr. The active ingredient in it is acultramon, and essentially what it does is it activates TRPM8 receptors, which are cooling receptors on the surface of the eye, and it activates tear production in as early as 3 minutes after installation. And then the one that we're likely going to be seeing here shortly in 2026, I can't believe I'm saying that, is a molecule that was initially developed through Aldera, but is now being further researched through via AbbVie. And it's Reproxalap, which is the active ingredient. Reproxalap is a RASP inhibitor. RASP stands for reactive aldehyde species inhibitors. Aldehyde are present in our tissues all the time. They're upregulated in times of inflammation, and all Reproxalap does is it captures that aldehyde and inactivates it, reducing inflammation.